So now let us begin the special lecture of ASE President, Professor Michael Awad. So Mike, first of all, on behalf of Japanese Association for Surgical Education, I'd like to express my gratitude that you have joined our meeting and give us your lecture today. So Mike, let me introduce you to my colleagues and participants in Japanese first, and then about your outstanding achievement in the field of not only upper GA and surgery, but also surgical education, both nationally and internationally. So, 今日の特別講演、マイケル・アワード先生で、アワード先生は、ブラウン大学を卒業されて、レジデンシーは、ジョンズ・ホプキンスで学ばれて、フェローシップは、内視鏡外科ですね、オレゴンで学ばれた後に、外科医として今活躍されています。もちろんですね、アメリカの外科学会 ACS またはセージス内視鏡外科学会でももうリーダーシップ執行部としてリーダーシップを取られていて、そして現在ですね、今年の ASE アメリカの外科教育学会の会長でいらっしゃいます。アメリカ国内の外科教育だけではなくて、日本ですとか海外のインターナショナルなエデュケーションにも非常に興味を持たれていて、今回レクチャーをいただくことになりました。です。リサーチはアッパー GI のクリニカルリサーチだけではなくて、もちろんシミュレーショントレーニングですとか、カリキュラムデザインに関しての、論文、業績が多数あります。学会賞も非常に多く受けていらっしゃることです。そしてですね、今回アワード先生には謝礼として日本円で5万円をお支払いするお話をしたところですね、ぜひこの研究会のために使ってほしいということで、寄付をいただきましたので、その点もお礼申し上げたいと思います。Mike, I'd also like let everyone know that you have donated your lecture fee to our society. So we are most grateful for your kindness. Thank you very much. So can you start your lecture, please?
Yes, of course. And Ohayo gozaimasu. Onamae wa Michael Awad desu. Good morning, and thank you for the distinct honor and privilege to join you on this very special occasion. I'm very pleased to join you today. I will begin to share my slides. And Yo, can you confirm that you can see the slides?
Yes, perfect.
Very good, thank you. Again, good morning, and it's my pleasure to present to you today. Again, my name is Michael Awad, and I'm president of the American Association for Surgical Education. Today you'll be speaking about a topic very near and dear to our society and some of the work we're doing here on video-based assessment, hurdles, pitfalls, and promise. I have just a few disclosures that are not relevant to my presentation today. First, I want to extend my sincere gratitude to Dr. Kuroshima, who is one of the founding members and the president of the Japanese Association for Surgical Education. I am very grateful to know him as a colleague. He has contributed much not only to the Japanese Association for Surgical Education, but also to the ASE itself. He himself has been recognized many times in his career, also by the ASE itself, recently with the Mid-Career Educator Award. So thank you very much, Yo, for this opportunity to speak to your distinguished group. I also want to extend my congratulations for this 10th year anniversary of the JSE. It is wonderful to see how the society has grown and developed over the years, and to partner with you in advancing the science of surgical education around the world. So congratulations, and wonderful to see this milestone and great accomplishment. Again, I have the distinct pleasure of serving as the president of the ASE this year, and want to just briefly highlight a couple of things that we again hope to make all aware of and to engage you in. The ASE is really a community of surgical educators, and we are very proud to be as inclusive as possible. And while it started in North America, we do welcome educators from all over the world, including the preeminent educators in Japan and beyond. Some of the programs we offer, a new one is called Atlas, which is advanced training in laparoscopic surgery. This is meant to kind of further the certification of advanced laparoscopic skills. We're very excited to publish our new journal, Global Surgical Education, and we invite submissions from you all to this journal, which is again focused on surgical education around the world. We have several premier programs, including what's called SELF, SURF, and the Fundamentals of a Career in Surgical Education for those that would like to advance their careers in surgical education research and leadership. We have a new program we're launching this summer, which is known as Ascent, which is a program for surgical education fellows. These are residents and fellows who are spending a year to learn about the fundamental principles of surgical education and research. And finally, we always welcome submissions for the ASE Awards. We have several awards that we grant from the ASE Foundation every year to support premier surgical education research, and I would welcome your submissions as well. Also, we would welcome you to join us in the ASE Fall meeting. This will be a virtual meeting held next month in October. And in fact, we have an international program as part of this meeting. Yo and others will be attending as part of this international program, and we hope that you can join as well. Again, it's virtual, and we would welcome you to attend. And of course, our big event every year is the annual meeting in the spring. This year, it will be in Orlando, Florida, in April of 2024. I hope that you can join us in sunny Florida for this exciting event. Again, we have an international program, and we look forward to your attendance and participation. So with that in mind, I'm going to now begin my discussion about video-based assessment. First, we'll briefly discuss some definitions about assessment, the current state of assessment, as well as some of the challenges. What is video-based assessment, and also the barriers to implementation, and how we can overcome those barriers with the future of assessment. So first, some definitions. Many of you may be familiar with this so-called 6 steps of curriculum development from David Kern and others. It is an excellent textbook that I recommend to you, but we'll be focusing on step number 6, which is at the end of any curriculum, we want to assess our learners to make sure that they have achieved those learning objectives. So this will be the focus of our talk today. The goals of assessment in medical education are to provide direction and motivation for learning, knowledge, skills, and professionalism. We want to adhere to the public and protecting them by upholding high professional standards, and also making sure that our physicians are qualified and competent. We want to meet those public expectations that we monitor ourselves and choose amongst applicants for advanced training programs. We won't spend too much time on this today, but we know there are formative and summative assessment, and our discussion will cover both types. Now, assessment best practices. This is an excellent article that I would recommend to you, published in the New England Journal of Medicine in 2007. But really, the main one we're going to focus on is the last one, which is provide timely feedback and mentoring. So the current state of assessment. Our current training system is basically based on case numbers. At least in the United States, the trainees keep track of how many procedures they have done, how many of the index procedures, what are the hardest cases. But we know that case number by itself is not sufficient to determine competence. And so The other issue with our current system is that it is a fixed time. In the United States, everyone does surgical training in 5 years, but we know it is not a linear path. For many people, this path can be circuitous, with many turns and twists and challenges. Some people need more time, some people need less time. And so we cannot just assume that everybody will be done and at the same quality of training at the end of the 5 years. Also, in the United States, we have many of these 6 core competencies, and they're useful, but it can be very challenging to assess them. We know how to assess medical knowledge and patient care. We can sometimes assess communication skills and professionalism, but it can be very challenging to assess these other competencies of systems-based practice and practice-based learning and improvement. Currently, the main assessment system is based on many assessment forms. We are all familiar with these grading rubrics, and while they can be very valuable, they're primarily based on numbers, scoring individuals based on a number of domains. But oftentimes it can be hard to determine what to improve on when we get a score of 4 about visual spatial skills. It's hard to know what this means. Is this a good score, a bad score? What can I do to improve? It is really kind of the narrative feedback and that is rich and can help us to improve. Other issues with our current assessment techniques, there's often a lag. It can often take time after the training event to get the feedback. The feedback is often infrequent. As I mentioned, we focus on scores rather than on the narrative feedback. The feedback also tends to be fairly minimal. It can be very fraught with bias and subjectivity. There are many, many articles now in the literature about bias in our assessments of our trainees, both the students and residents alike. These bias can be affected by the trainees' racial, ethnicity, gender, and age. So we can do better with our assessment. In fact, we really must do better. There's a famous retired ice hockey player named Wayne Gretzky that has a famous quote, "Skate to where the puck is going, not to where it has been." And this is what I'd like to focus on today, is the future state of assessment. Now, specifically, the use of video in assessment is an exciting field and one that's very important to the ASE and is one of our big initiatives in this year. Now, the use of video by itself in assessment is nothing new. In fact, we've had video for many, many decades. Many of you may remember these formats of how we used to record video. And video has been used in other fields, in particularly sports, for review of performance and providing immediate feedback. In fact, the use of video in sports is a formal science where you can look at performance in the video frame by frame. You can have objective metrics that can provide feedback and longitudinal data to the trainee and their coaches about their performance. And so what about in medicine? Well, again, we have had video for a long time, even from these days when we used to look through the laparoscope, was the beginning days of recording video. And there are many potential advantages. The assessment can be done blindly, helping to minimize bias from the mentor and the trainee. It also allows reviews by multiple reviewers, leading to more accurate assessments. The video can be reviewed by the trainee themselves and be used to kind of improve their technique and provide feedback. And it can lead to skill development and improvement. The use of video in assessment has been exploding dramatically, especially in the last decade. And alike, there has been a number of commercially available products to help record and analyze videos and help us to provide this feedback. Now, one of the main things is, does video actually help us to improve our clinical outcomes? And in fact, there is good science that it does. This was a very important article published 10 years ago in the New England Journal of Medicine, looking at complication rates after bariatric surgery. In this study, they had independent reviewers review performance of live surgeons doing bariatric surgery and rating their performance. On this graph, on the horizontal axis, you can see the rating of those videos. On the vertical axis, you can see the complication rates of those procedures. And you can see there is a very strong correlation with improved performance and lower complication rates. And in fact, this is true of any complication, including surgical as well as medical complications. And as a result, based on this and many other studies since then, our society, as well as many others, including SAGES, has been working on developing assessment tools for the use of analyzing videos. This is a video-based assessment tool for laparoscopic fundoplications. The tool includes a very detailed rubric looking at each step of the fundoplication and having an independent blinded reviewer assess their performance. There are tools now commercially available to use these grading rubrics while you're watching the video to help score the video and provide that feedback. Now, this sounds wonderful, but why don't we use video more? Again, video has been around for a long time, but we really don't use it very often. And why is that? We published an article a few years ago where we surveyed 642 minimally invasive surgeons and asked them, what are the barriers to using video regularly? Well, as you can imagine, a big factor is time. The time that it takes to acquire the video, to review the video, to edit the video. Technical issues. How do we acquire the video? How do we transfer it? How do we edit? The files are often very large. It can take time to transfer them. There can often be hospital regulations around the use of video, and also legal issues around who owns the video. Does it belong to the physician, the patient, the hospital, or otherwise? So how do we overcome these barriers? And now I'd like to change gears and talk about the future of video-based assessment. One of the things that I'm very excited about is so-called objective performance metrics. This is data that comes from our surgical procedures that can give us feedback about the performance. Things like the economy of motion, the collisions, the use of the camera, and so forth. Now, we know that the surgical robot has been around for many years, and we can think of this as a computer between the patient and the surgeon. And as a computer, we can acquire a significant amount of data. For years, this data has been available in simulators to give us feedback on our performance, but it hasn't been available to us clinically for use on live surgical cases until recently. There is also data that can come from non-robotic laparoscopic procedures, where the tips of the instruments can have markers on them, and we can use them to analyze the motion of the instruments and provide feedback again and quantification of the performance. This is an example on the left of a robotic procedure performed by an expert. You can see the red dots are the left hand, the blue dots are the right hand, and on the right hand side, you can see the novice performance. And very quickly, you can tell the difference as far as the randomness of the movements and the efficiency of the motion. And this data can, again, be quantified and compared to experts. Again, these are diagrams showing the performance of the expert versus the novice and can be used to improve performance. There are also now tools with natural language processing. When we dictate a note, when we dictate feedback, or even during the operation itself, when we are giving feedback to the trainees, this language can be recorded and analyzed. This is an example of natural language processing that is taking words used during a procedure to analyze the trainee's performance. On the bottom right, you can see the words that are captured, things like independent, complete, straightforward, and so forth. And it can be used to assign a score to the trainee on the top right of 1 through 4, again, just based on the words that is used by the faculty to the trainee. Now, artificial intelligence, machine learning, and deep learning is we've all heard about significantly in recent years. And this is a very exciting field. For a long time, we know about its use in the automotive industry. We have now self-driving cars that can analyze the lanes on the road and keep the car between the lanes. It can even identify pedestrians or animals in the road and try to automatically apply the brakes to avoid collisions. Can we not use this similar technology in our surgical procedures? We entrust our lives to these self-driving cars. What about with our patients? Well, this too is, again, in a very exciting time now. There's studies looking at, just for medical students, looking at videos and having machine learning analysis of the videos of medical students' suturing skills and actually providing them feedback. We have found that these videos actually correlate very closely with the traditional methods of a surgeon providing a grading to the performance. And also now with not just simulated skills, but live surgical procedures. You can imagine now with the same technology we have for analyzing vehicles on the road, you can do the same with cholecystectomy. And these systems have taken many, many thousands of cholecystectomy videos and put it in these algorithms, and the machine begins to learn what are the safe areas, what are the dangerous areas, what are the critical views of safety. In this video that we'll show you here, you'll see here on the right-hand side, a cholecystectomy being performed. And on the left-hand side, the machine is automatically determining what portion of the procedure is being done. Is this dissecting the scar tissue from the gallbladder, dissection of the hepatocystic triangle, clipping and dividing the cystic artery, clipping and dividing the cystic duct? You can see all of this is being done without any human intervention. This is completely the computer determining the phase of the operation. In a similar way, we can find that the computer can determine the complexity of the procedure. On the left hand is that same type of graph for a simple gallbladder, and on the right hand is showing a different graph for a more complex gallbladder. So you can get kind of a fingerprint of the complexity of the procedure that is also very important when we assess our trainees. These complexity adjustments can help us when we are grading performance. And these fingerprints can also be used not just for the complexity of the procedure, but also of the surgeon's performance. Now, again, it's not just the phase of the procedure, but even very specific surgical components. So we all know about the critical view of safety, identifying the cystic duct and cystic artery before we clip and divide them. On the right-hand side, you'll see as soon as we flip this over, the CVS equals 1 is now showing on the screen. So again, the computer has recognized when that critical view of safety has been achieved. In this, we also now have what's called augmented reality, a so-called overlay of the safe areas, the green parts where it is safe to dissect, versus the dangerous areas near the common bile duct and the duodenum in red, which is not safe to dissect. We have taken these initiatives and studied them, again, through a grant from the ASE and also from Intuitive, the maker of the surgical robot, to look at other types of ways we can provide training, feedback to the trainees. This is now available on the smartphone, where you can look at how much of the procedure was done by the surgeon and how much was done by the trainee. Our goal is that at the end of the rotation, and certainly by the end of the residency program, we see more bars in the trainee and less bars by the attending surgeon. That is, the trainees doing more of the procedure by themselves. We recently looked at this data that was coming from the robot to look at objective performance metrics for trainee participation in robotic surgery. On the left-hand side, you see the percent of the procedure that is being done by the trainee as measured by the robot. And you'll see that it correlates with advanced years of training. On the left-hand side, this is the first year of training, and as you'd expect, this is a relatively small portion of the procedure done by the resident. But as they go to their third and fourth and fifth year in their fellowship, more and more of that procedure is being done by the trainee, and that is our goal. You can also break it down into complexity, and you can see, as expected, with the standard case, the trainee is doing more. With a more complex case, they may be doing a little bit less. Now, we also have the capability to record the videos automatically when we're operating. These videos are available immediately after the procedure, and the computer, again, is automatically segmenting the procedure into its core steps. This helps us to reduce those barriers with time. So especially if you want to focus on just one component of the procedure, we don't have to review an entire 2-hour video. We can go directly to that portion that we're interested in. Here too, we're published on looking at the percent of the procedure done by trainees broken down by specific steps. And again, these tools are helping us to do this much more easily now. You can compare your performance to expert performance and also see how you're doing on your own time compared to an expert. And now to help eliminate or reduce some of that bias, you can use objective performance indicators. These are things like how you're controlling the camera, your economy of motion, how you're clutching the instruments. And you can look at your performance over time and see that, in fact, your efficiency is improving. And again, we want to reduce the amount of time that it takes to provide feedback to the trainees. We know that for every minute after the procedure, when we leave the operating room, the chance of us providing feedback to the trainees goes down dramatically. So what can we do to reduce that lag time? We now have tools in the operating room where we can record the procedures automatically. These procedures are available within 1 to 2 minutes in their full length, right after the procedure is completed. Even before the patient wakes up from the operating room table, we can sit down with the trainee and go and review specific steps of the procedure. This can be reviewed on the desktop, and you can see different bookmarks of specific parts of the operation. Again, in case you don't have time to review the whole procedure, we can at least focus on specific moments. And here's myself with another trainee. Again, we're still in the operating room. The patient is still waking up, and we're talking right then and there about specific parts of the procedure. This video is also available on the smartphone, so the trainee can go back and review it on their own time. And we're using these videos now for coaching. Coaching is kind of a formal program where we're helping the trainees to help themselves to understand their own performance and what they can do better. We have a grant with the Academy for Surgical Coaching, where we are providing formal training for surgical faculty to be coaches. And they take the videos and they review it with the trainees and provide them with that feedback. This study is ongoing, and we look forward to presenting the results of this at one of our future meetings. So in summary, regular and thorough assessment is critical for the development of safe and efficient healthcare providers. Video can be an important component of assessment. It's not the only component, but itself can be an important adjunct. Barriers to video-based assessment include time and access to the videos, but some of the new technology and tools can help us to mitigate these barriers. Again, I thank you for the opportunity to present. Again, I would like to encourage you to join us at the Fall ASE virtual meeting in October, and again in person in Orlando. Domo arigato. Thank you very much.